Good afternoon, and thank you to the committee for allowing us to present our research on transportation barriers and health status in middle-aged and older adults living with HIV in the Deep South. So as many of you know, the epicenter of the HIV epidemic has shifted in the US over the decades, from metropolitan areas in the Northeast and West Coast to the South. The Deep South, which is comprised of 9 states as seen in this figure to the left, so all the southern states minus Kentucky, continues to be disproportionately impacted by HIV/AIDS, especially for communities of African Americans and men having sex with men. The disease concentration and poor health outcomes seen for people living with HIV in the Deep South, we know is driven in part by socioeconomic factors. Therefore, identifying and addressing these factors will help us improve health outcomes for people with HIV and better connect them with the services and care that they need. So one of these socioeconomic factors is transportation. Transportation is a social determinant of health that touches multiple aspects of an individual's life across the lifespan. Access to reliable and adequate transportation is often overshadowed in aging research, as we tend to be heavily focused on crash safety and how age impacts necessary abilities to operate a vehicle, such as cognitive and physical abilities. When looking at the literature at the significance of transportation barriers in all individuals living with chronic disease, what we find is that greater transportation barriers is associated with more canceled or missed healthcare appointments, delayed care or lapses in care, poor medication adherence, and overall poor disease management. Notably, what's lacking in the literature, especially for HIV/AIDS, is how transportation barriers are associated with health-related quality of life, defined as one's perceptions of physical health and mental health over a defined period of time. Therefore, the particular focus of this study is how transportation barriers are associated with health-related quality of life, given its importance in overall well-being and its correlations with mortality. To do this, we used the baseline sample of the Think Fast study, which was conducted at the University of Alabama at Birmingham. This included 261 middle-aged and older people with HIV who were recruited from the UAB 1917 clinic. To answer our questions, we used demographics, so looking at the individual's age, race, and proxies of socioeconomic status, as well as rurality based on the zip code of their residence. We looked at HIV characteristics, so clinic-drawn CD4 T cell counts, as well as viral load, and also with HIV duration, so years since diagnosis, as well as self-reported medication adherence. To capture health-related quality of life, we used the MOSE HIV, which is a normed version of the SF36 on HIV/AIDS populations. We also captured depressive symptoms using the CESD. To look at perceived transportation barriers, we took a twofold approach. So first, the main way that we looked at transportation barriers was through a transportation question from the Barriers to Care scale by Heckman and colleagues in 1998. This question asked how much of a problem was it for that individual to access the care, services, or opportunities that they needed. From there, we also looked at other components or correlates of transportation barriers, such as does the individual actually own a vehicle or have access to a vehicle when they need one? Do they have to miss healthcare appointments because of transportation needs? And how frequently do they have to schedule their healthcare appointments around transportation? So looking at our overall demographics of our sample, what we see is that our sample is on average about 51 years of age, and they have a high school education. They were majority male, self-reported male gender, and African-American race. When looking at household income before taxes, just over half of the sample reported 10,000 or less. They also reported being disabled, and the large majority of them were not employed. When looking at rurality, the majority of our sample did live in an urban area or cluster. And when looking at HIV characteristics, what we see is that about 28% had detectable viral load. Almost the entire sample was currently on antiretroviral therapy, and the median CD4 T cell count was 636. So from a disease management standpoint, these this group of individuals was well controlled. To orient you to the health-related quality of life domains, so the MOSE HIV has 11 domains, which are listed here in this table. We chose to look at the individual domains instead of just total mental health versus physical health to give a better description of what aspects of health-related perceptions or health-related quality of life perceptions were actually being affected or associated with transportation barriers. Health-related quality of life scores are transformed on a scale ranging from 0 to 100, with higher scores indicating better perceptions of health for that specific domain. It also reflects their perceived health within a 4-week time period from when that questionnaire was completed. So from our sample, what you can see is that the lowest scores were reported for general health perceptions, pain, and energy and fatigue. So first, we did a series of Spearman-Rowe correlations that were unadjusted. What we found was that greater perceived transportation barriers were associated with being non-white race, having fewer years of education, and having a lower annual household income before taxes. It was also associated with greater medication non-adherence, greater depressive symptoms, and having a higher viral load. Lastly, greater perceived transportation barriers were also associated with not owning or having access to a car, having reported missing or canceling a healthcare appointment because of a lack of transportation, and more often having to plan healthcare appointments around their transportation needs. We then did a series of hierarchical linear regressions. Each model had the following covariates, so HIV duration in years from diagnosis, their CD4 T cell count, viral load, race, income, and depressive symptoms. It's also important to note we had a smaller sample size for the linear regressions because the clinical values were missing for some of the sample if they didn't have a recent value drawn within a 3-month time period from when we pulled the data. So the analytic sample for these regressions was 178. So what we found was after accounting for covariates for every unit increase in perceived transportation barriers, there was an associated 4.59 reduction in general health perceptions, a 5.41 point reduction in pain, a 4.37 point reduction in social functioning, a 3.59 point reduction in health distress, and a 4.36 point reduction in physical health and emotional conditions, or what the MOSE HIV calls health transitions. So in conclusion, what can we draw from these findings? And what does it mean for the future? So first, we know that access to reliable transportation is a key social determinant of health that promotes health equity and quality of life for people with HIV. What we can infer from these findings is that those who may be the most vulnerable are also the ones who are experiencing difficulties with accessing reliable transportation to healthcare appointments. So we have to ask the next question, do transportation barriers actually lead to poor health-related quality of life, or are they happening at the same time? Additionally, if they do lead to poor health-related quality of life, what potential mediators or moderators may be driving this association, such as depression or any other social demographic factors that maybe we've looked into or have missed with this recent study? From there, we have to ask the question, how has COVID-19 impacted this situation? It's not a far-fetched idea to think that if individuals who don't have access to reliable transportation and are having to rely more on public transportation options or friends or family members, that the COVID-19 pandemic, as well as having to social distance, has probably increased the burden or made this situation even worse. From a healthcare implication standpoint, assessing transportation barriers is especially important for individuals who are not medically fit to drive, who lack the financial means to drive, or reside in geographic areas with underdeveloped public transportation. Therefore, healthcare providers are encouraged to assess transportation barriers in this at-risk aging population as cognitive mobility needs may change with age, therefore increasing the potential burden for these individuals. So with that, I would like to thank my co-authors, Dr. Despina Stavrinos, Dr. Perry Fazeli-Wheeler, and Dr. David Vance, all who are at the University of Alabama at Birmingham. our institutions and departments at UAB, as well as the University of Kentucky and the University of California, San Diego STAR program for their support with this research, along with our funding from the National Institutes on Aging, the National Institutes of Mental Health, and the U.S. Department of Transportation Federal Highway Safety Administration. And with that, I thank you for your time, and I welcome any questions.